Carolina. My name is Brady Hanshaw. I work with UNC Health, and I'll be helping just moderating today's discussion along with the Q&A session afterwards. So today we will hear from 3 infectious disease experts with time for questions following their presentation. We'll also be recording this so you can share afterwards or review afterwards. And we just wanted to remind everyone of the chat feature for your questions with Zoom. So today we are joined by Dr. Cameron Wolfe, Dr. Lina Rosengren-Hovee, and Dr. David Wohl. They are all 3 infectious disease experts working with UNC and Duke Health, and I'll let them tell you a little bit more about themselves. Dr. Wolfe, do you want to start?
Yeah, sure, Brady, and welcome everyone. I'm an adults infectious disease doc over at Duke. I do transplant, HIV, and then sort of emerging infection issues, and so happy to join you. Maybe we can pass to Lina.
Yeah, hey everyone. Lina Rosengren-Hovee. I'm an assistant professor at UNC Health. I'm also an adult infectious disease doctor. My clinical work is focused on HIV, STIs, and gender care. And outside of that, I'm a stigma researcher primarily.
Great, and that leaves me. So I'm David Wohl. I'm at the University of North Carolina, Chapel Hill as well with Lina. And like my colleagues, I am an infectious disease specialist and have done HIV related work for a long time. And more recently, over the last few years, certainly emerging infectious diseases, including COVID and now a bit of monkeypox.
Great, thank you. Do you want to go ahead and lead the conversation forward, Dr. Wohl?
Yeah, thank you. And thanks for kicking us off. Just some reminders, we're going to leave the mics on because there will be some discussion amongst ourselves, especially, but so please mute if you're not a speaker right now. We're going to have the chat feature where people will be able to type in their questions, and we'll try to respond to those as we can. So please just really be careful about the mute because that definitely can make it really hard for us to speak where there's barking children and crying dogs. So let's move on. So my colleagues and I thought a lot about what we should do for this event. And the genesis of this was there's a lot of concern and worry about monkeypox, especially in the communities that are most impacted right now. And so we figured it might be smart to just get out there, get ahead of this, and try to put out some information, some factual information from people who've thought a lot about this and push this out there now. And this is going to be recorded so we can continue to do that and that other people can watch this and hear more about where we're at with monkeypox. And that's really what this is about. This is about where are we now? What is the situation today? And then getting into some of the nitty gritty because people have questions. What should I look out for? What do I do if I think I could be infected? What do I do if I think I'm at risk for infection? And then really importantly, how do we do this kind of work thoughtfully, inform and help communities that are disproportionately impacted right now by a monkeypox, but do it in a really sensitive way? And then we want to open it up for questions and also some discussion. And the idea, if we are good at this, is to try to split this up almost evenly. We might take a little bit more time talking the talk because we want to make sure we cover things and then leave time for questions. But hopefully get through the top part relatively quickly and efficiently so that we could have more of that Q&A. Again, don't forget to type your stuff into the chat. That's really important. And Brady's monitoring it. He's going to keep track of this and he'll push out the questions. So let's start with the first thing. What's the situation? Well, what is monkeypox to begin with? Like probably the vast majority of us, even infectious disease providers, had not heard of or heard much about monkeypox. So it is a virus. Okay, so monkeypox is a virus. We're all getting, basically, degrees in virology during COVID-19. We understand a lot about viruses. We understand more about PCR, about spike proteins. So this is just another virus that's out there, that's been out there probably for eons. Okay, it does not really infect monkeys. That is not the idea. This just happened to be a virus that infected a troop of laboratory monkeys. And the researcher said, what's going on here? and they tested and they found this virus, but the monkeys got it from another animal, just like we can get it from another animal. It's probably from a rodent type species or species that live in certain parts of Africa. So it isn't carried by monkeys. If you're cuddling with a monkey, chances are you will not get monkeypox. It is spread by close contact. So yes, so cuddling, smooching, rubbing next to somebody. This is the predominant way that we see this virus spread from person to person. You do not get it on an airplane. If you're sitting in row 3, seat D, person 2 seats behind you, probably even the person next to you is probably not going to get monkeypox, certainly not people not touching you. It's not an airborne infection like COVID-19. Okay, and as I said before, it's found mostly historically in certain parts of Africa. It's really interesting. It was in basically Central Africa for a long time, but has been spreading within Africa. And we are seeing some spread towards the West where it wasn't before. So it's not like these are definitely places where we've seen the virus for a long time. Even within parts of Africa where we're seeing monkeypox over many years, we're seeing its domain increase over time for reasons that we can get into maybe during the Q&A. So here's sort of the situational report as of yesterday. So we know that there's been about 14,000 cases, 14,500. A few hundred of those are in countries that have historically had monkeypox, and those are indicated in blue. And that's in that region I talked about. In orange are places that don't historically have monkeypox. So that's the vast majority of these new cases. Now, there could be more cases in that part of Africa that's highlighted here, but there may not be the diagnostics that we need to detect it. So I suspect there's a lot more cases there than we know about, but certainly we're seeing, and this is really spread over time. If we did a time lapse, a lot of these places wouldn't have an orange dot, or if they did, they'd have a small one. So this is growing, and this will continue to grow over time, especially now that we're having more testing. We know right now, and we have Zach Moore, our state epidemiologist and lead here from the state on the call, and he and his team can help us understand more of the up-to-date information. But reportedly, there's about 20 cases here in North Carolina that are confirmed to have monkeypox. And given some of the information that they shared with us, the median age right now of these 20 cases is 32. That means half are above and half are below that age. All are men. 12 are African American or Black, 8 are white, and 20 report having sex with men. So that's going to help us understand who's at risk right now. In all the countries that we're talking about that haven't historically had monkeypox, we are seeing trends that show us that this is really spreading within networks, particular networks, including networks of men who have sex with men. And that's a situation that exists right now, but I don't think many of us think that that's going to stay that way. And there's already some indications that it's going to expand to other networks that the virus finds. Women have been infected. We are very, very worried about children getting infected because historically children don't do as well with monkeypox as adults. But again, this is not necessarily something that only impact men who have sex with men. So some bottom line top things that we should be thinking about. It is readily diagnosed. Okay, so there are tests for this. We can test for this. We can make sure whether or not somebody has evidence of the virus in their skin lesion or in their mouth or in their anus, wherever the infection seems to be. The good news too is that the rate of this becoming very, very serious or even deadly, even in Africa where we see this, in the parts of Africa, is really, really low, especially this kind of flavor or clade of monkeypox. There's two major types. This is the milder type that has been spreading outside of that region where we find it historically, and that's great news for us. So very, very rare that it causes something devastating, even in parts where we see it where there's not as good healthcare. There have been 0 deaths outside of Africa. It is not extremely easy to spread this, as we talked about. It takes some contact. There are reports of droplets, of people shaking their sheets and things like that. With this outbreak, it doesn't seem to be really the motive force. It doesn't seem to be the engine for the spread of the virus from person to person. It does seem to take more intimate contact. As we'll talk about, it's treatable and preventable. And the key thing is, this is not COVID 2.0. This is a different type of virus. It spreads differently, as we talked about. And that's why we're talking about several thousand and not hundreds of thousands or more than that. So really key. This is a very, very different type of contagion than that we've been dealing with when we talk about things like influenza or for COVID-19. Don't forget to mute your line if you're just joining us. Thank you. Okay, so next thing we're going to talk about is what to look out for. And I'm going to turn this over to Cam, who's going to share with us some information about things that you should be on the lookout for as far as monkeypox.
Yeah, thanks, David. And I think you now should, we've done this seamlessly and my screen's up, I think. So let's get into a little bit of clinical symptoms. So number one, many people, but I wouldn't say all, often describe in hindsight having what we call a prodrome. So this early illness that feels very consistent with many flu-like illnesses. It may be indistinguishable from COVID, to be honest, where fevers, flu-like symptoms, muscle soreness, fatigue, maybe some glandular swelling is predominant. And in many people, that's lasted a day or two before the more notable symptoms, which this illness is more famous for, which is the rash develop. And the rash really goes through some evolutionary stages in almost everyone that make it pretty characteristic. The first is it starts as a flat and then eventually raised rash that forms a blister, very indistinguishable as an initial lesion at that point from what we may see sometimes with herpes blisters or even chickenpox, although they're not related infections. They tend to develop, as we'll show some pictures, into pustules, and then eventually over time that lesion loses its roof, starts to heal and flattens back out, sometimes with a scar. You can see different phases of sort of evolution of these blisters and pustules at the same time in the same individual. And although I think many of us might have, been tempted to sort of Google traditional pictures of monkeypox where we would see sort of many areas of diffuse spots on the skin, that's actually the less common presentation of what we've seen so far in 2022, where often the blisters have been limited to sort of set areas of the body, sometimes the mouth, often the genitals, occasionally internally, particularly around the anus or the mouth, or they can be more diffuse. So it's quite a variable presentation. There's nothing to say that people can't have more than one infection at the same time. And certainly, as we've seen, if this is spreading through sexual networks in particular, the potential for other STDs to look very similar, I think, is something that clinicians and patients are going to have to sort of contemplate. When we would tend to think about fever and a rash in a clinic setting, the other things that can look pretty similar include occasionally syphilis, new herpes infection, chickenpox can look similar. There's a number of other STDs that look similar and they can co-occur. So there's sort of good motivation here to, if you think that these are occurring, to seek care, and we sort of start sifting through those. The spots themselves, as I said, are very variable. And you can see hopefully here, for example, if you look at the one that's second from the left on the top, something that looks like you could imagine that there's fluid in them. Others, as you go down onto that bottom line, look more sort of pustular in their content. They contain pus like a boil. These are typically painful, although not exclusively. Some people actually pain becoming their overwhelmingly biggest symptom. As they develop, they can be in lots of different sizes and shapes, which again makes this clinically a diagnosis I think we just need to be thinking about. You can see that some of these are pretty subtle. Some of them might look like standard skin bacterial folliculitis that we get, although you can sort of see here the sort of more the often widespread distribution that can occur. There's few things that occur on the palms of the hands. That's often a good clue that something's going on. And again, these compared perhaps to sort of standard herpes or chickenpox lesions, a little more firm, a little more rubbery, and again, often quite painful. They can be internal. So here's an example shared through the CDC of a gentleman who had sort of hard palate lesions in the inside of the mouth. They can occur in the eye. This is not a representative example, clearly, but some people present with conjunctivitis, so an inflammation of the surface of the eye. And what may be particularly difficult to diagnose is that these can be intraanal and rectal. and people will present actually with pain using their bowel motion, pain during sex, and examination can show the ulcers on the internal aspects of the anus. So with that in mind, I think it's also helpful to understand sort of progression. As David mentioned, like reassuringly, the first thing is severe cases here requiring hospitalization in Europe, in the US, have so far been very rare. You know, there are some people who, from a pain control point of view, have needed hospital. Occasionally those blisters can become secondarily infected and people need antibiotics. Very uncommonly would folks get the sort of the more severe end of the spectrum where internal organs are affected. Although we are sensitive, I think, to patients who may be, say, immune suppressed or have a weakened immune system where that's at least plausible. The progress is that the majority of people here will get better. These lesions can scar, so it's not necessarily a complete recovery for everyone, but we consider their illness ended when those blisters and sort of pustules have often shed their roof, formed a new skin layer underneath, flattened out and scarred down, and people become no longer infectious once that's really occurred. The challenge is that that can be a while. This is not a sort of 5 to 7 day illness for COVID. This is sometimes some weeks before the full evolution of those lesions take place and people are no longer infectious. So an important part here actually is to, I can see someone drawing on my screen, it's not me. An important part here is actually to, you know, be prepared to put your hand up pretty early on and let us identify if you've got symptoms that fit with this. And we'll get into testing early shortly, because then you can do something about it. You can put yourself in a position where you're not going to infect others. So what do you do if you're worried? And David, I'm going to pass back to you.
Perfect. And we'll try to do the seamless thing right now as well. So let's try this. All right. So
There you go.
What to do if you are worried that you might have monkeypox. So the good news is, as we talked about before, is that we have tests, and we have tests that we can use. And again, like I said before, a lot of folks now understand more about this because of COVID. COVID has been a crash course in diagnostics for things like viral diseases. So people are pretty familiar with a swab that goes in your nose to look for the SARS-CoV-2 virus that causes COVID-19. Similarly, we can take a swab of a lesion. So Cam showed you some really important pictures of all the different types of lesions people can have. Some of them are already open and wet. Some of them look like they have some fluid underneath them. And that's what we want to get at. We want to get at the fluid. What we know about monkeypox, like we know about most pox diseases, infectious diseases, is that the lesions are usually teeming with the germ. And so we really want to get down at the base of that. So what we can do is use our swabs, and there's a swab here, a picture of one sort of, that didn't come out perfectly. And you can kind of just like wiggle it around. And oftentimes that alone, if you're aggressive enough, will unroof, we call it, the lesion if you have one of those bubbles. If it's already open, you just have to swab it. And this swab can be used to be sent to a lab for that PCR test. In this case, we're PCRing the virus for monkeypox. In the mouth, you could do the same thing. And what we've also heard about and seen a little bit of is rectal pain, as Cam mentioned, and proctitis is the official medical name for it. And if you don't see a lesion, it's still okay. We can put the swab into the anal area and swirl it around there and probably retrieve the virus. Again, this is where we find it, is on the skin, on these shiny surfaces. That's where we'd find it. Now, great news, just, hot off the press, just over the last few days, is the state had been doing, all the testing at their lab in Raleigh, and now some of that burden is shifting to commercial labs. And the federal government is really trying hard to make sure that there's capacity to test a lot more people. We're talking of tens of thousands of people per week being able to be tested. I think a number I read, and Dr. Moore can help us, but like 80,000 a week is what we're at right now, and it's going to expand. So that means there's going to be more testing at the laboratories, which I think will help us be able to diagnose more people with monkeypox. So where to get a test? Well, we have a lot of laboratory capacity that's building up. What we now have to do is get, a legion of swabbers. And so Cam and others are trying really hard to make sure that there are more and more providers that can know about the test, know what to look for, be able to use the right swabs to do it the right way. And we've tried to describe a process that's pretty simple for sending it either to the state lab, where it could be done really quickly. So the state lab turnaround has been remarkably swift, or to one of the commercial laboratories. And there's a number of commercial laboratories that either are doing it now or will come online soon that the state is working with. And that again will hopefully be a quick turnaround time. And there's easy ways that a lot of clinics have to send their specimens to these labs already. So LabCorp is probably one that you've heard about. Many clinics and doctors' offices already have an arrangement with LabCorp where they could pick up samples. That would be it. Local departments of health can often help too. So whether they're doing the test themselves or not, when we contact them, either the providers or people who are concerned and they want to test, they could find out, hopefully with their health department's assistance, where nearby they can get a test. So this is a moving target. I think if we're successful, there'll be more and more places, I think at UNC and at Duke, and we can talk maybe a little bit more about that during the discussion, and elsewhere where people can get a test. One thing I'd say is just give them a heads up. I think if you go to a clinic cold and they don't know that you're coming and you're suspecting monkeypox, especially if it's a clinic you're familiar with, I think they may not be prepared. So if you could call first, talk to them, say, I'm interested in this, do you do this? That way it might save you a trip if they say, no, we're not doing this, we're not ready yet, but we know of a place that could. So unfortunately, some hunting around in these early days, but hopefully this will be more solidified over time. While, let's say you do get tested, it's going to take a day or two, hopefully not longer than that. And if you are positive, these same rules apply. But we really want people to not spread it to anyone else. And I think people can be pretty straightforward and logical about this. One is avoiding sex or being intimate really with anyone, staying at home, isolating from other people. And if you live in a household with other people, being away from those people. Again, this is not something that's going to go under the door. This is not something that's going to spread across the room. It's different than COVID. And again, if you can't fully separate, wear a face mask, avoid physical contact. And again, important, cover the lesions wherever they are, because those are the things that we worry could spread the virus. If there's wetness of the lesion and you touch something, that wetness can get onto that surface and it could be contaminated with the virus. And then just some practical things, of course, around the house, cleaning up after yourself, not sharing beds or bedding or towels, and washing your hands frequently. Question that comes up all the time is, well, if I am infected, is there treatment? And there is treatment, which is, again, good news. So tecovirimat is an antiviral that comes in both oral forms for pills and also IV form for people who really need it through an intravenous line. That would be pretty unusual, but it can happen. So good news is we have an antiviral. It is approved for smallpox. And we haven't talked much about smallpox. Smallpox is a virus that was devastating, for eons and has been essentially eradicated from our planet, except from some small stocks that are kept for research purposes under lock and key. And a vaccination effort led to the eradication of smallpox and at the same time controlled monkeypox, because as we'll talk about, the vaccines that work against smallpox work against monkeypox. And when we stopped vaccinating people for smallpox, once it was vanquished, monkeypox, which probably caused some of the disease that people thought was smallpox, monkeypox started to emerge. There was no longer any herd immunity, if you will, because we're all now experts in these concepts, no herd immunity against monkeypox now that there was no longer mass vaccination for smallpox. So this medicine is approved for smallpox, and as we'll talk about, it's being made available to treat monkeypox, which is very similar. It's taken twice a day for 14 days for most people by mouth, and safety profile looks really good. So who needs it? Well, right now we're trying to reserve monkeypox treatment for people who have weakened immune systems, who are young, pregnant, maybe certain skin conditions like eczema that may predispose to more severe lesions with monkeypox. If they get what we call superinfected with bacteria, so sometimes we can see a monkeypox lesion that isn't healing, and then on top of it gets bacteria in it, and can get worse and make people really sick. As Cam said, involvement of any of these really sensitive places, the eyes, the mouth, into the lungs, into the brain, anus, genital lesions that are very painful, this would be an indication for thinking about getting therapy. And TPOX is the brand name for tecovirimat. That would be what we would be thinking about. So someone who has a single lesion on their penis, feels well otherwise, probably not a candidate for TPOX right now. These are self-limiting, they go away. We don't have data right now that shows that this would hasten recovery, although studies are going to be conducted looking at that, so this may change. But right now, given the supply issues, how we're getting this, reserving this for people who are more likely to have a more rocky course moving forward. So that's the good news. The bad news is this is not as easy as prescribing and getting it at your local pharmacy. So right now, this is available through the Strategic National Stockpile, and it's available through the CDC through a kind of compassionate use program. And compassionate use programs oftentimes are almost research, but not quite research. It kind of falls in a gray area, but it does require some of the same kind of paperwork and requirements as research does. So this is really brand new. So we're all working, I know at Duke and UNC and elsewhere, on how to get this to people. And we've started down the pathway to identify people who could prescribe this at our hospitals and at our healthcare system so that we could have this available when we need it. So this is starting. There's rumors that the CDC is going to try to make this even easier than it is right now. But right now we have to submit some paperwork and basically get approved, then request the drug, and the state helps a lot with that. And then we get the drug sent to us, and then we have the individual sign a consent form. We fill out some paperwork, and then they can take the drug. And then we fill out some more paperwork as we follow people up. And there's options for giving blood to look at drug levels and things like that, and we can take pictures. So it is collecting the data too that's a part of this right now, but we'll see how this moves forward. So the question though is, like we said, what if you think you're at risk for being infected? You're not infected now, you don't have any lesions, you're not sick at all. And I'm going to pass it right back to Cam to kind of tell us a little bit about prevention. So I'll stop sharing, and I'm sure he's ready.
Apologies to mute myself there. You should already have stopped exchanging. I don't know where you get your cat photos from. I'll put that out. Prevention really comes in two forms, and Lina's going to address one, which is sort of safe contact and sort of a lot of behavioral questions. The other one is vaccines. So again, a fundamental difference here with the way we began to consider monkeypox versus COVID is that we already have a vaccine that we've looked at well before this issue has emerged. As David said, traditionally we had a smallpox vaccine called ACAM 2000, which had been around for many years and is still occasionally used in research and sort of laboratory settings. What's really, I think, been a game changer is the development of a vaccine from a company called Jynneos, which is a 2-dose vaccine given 28 days apart. People would remember the strategy of COVID vaccines is you sort of prime your immune system with dose 1, and then you really boost it and amplify that response with dose 2. And this vaccine does the same thing. It was designed against the array of pox viruses, which includes smallpox and, reassuringly, monkeypox. And actually, compared to the old historic smallpox vaccines that we used to use, has a better and really very efficient way of sort of stimulating your immune system. This is likely highly protective. It's also similar to what David described with tecovirimat, limited at this stage in terms of its availability. And I want to sort of walk you through a little bit in terms of the way that nationally and within the state we're trying to roll it out. And I'm glad Zach's online to also from the State Health Department to redirect my conversation or add to it if we need. So this is, again, a 2-dose vaccine. It's typically given in the arm as a subcutaneous injection. It's quite stimulatory. It's designed that way. And so I think it's reasonable to counsel, I certainly counsel patients who I see to say, look, it's not uncommon to feel some side effects after you have this vaccine for 24 hours. You know, we think of tetanus as one that notoriously causes us a sore shoulder. This does the same thing. We think of perhaps shingles in older adults, or maybe your first COVID vaccine is something that can often cause sort of fever, flu-like illness for 24 hours. This is often the same as well. So that's not the illness, that's your immune system getting just a little bit irritated by the vaccine in a healthy and productive way. And then people, typical of what we saw with COVID vaccines, will often develop a very strong immunity within a couple of weeks. So currently the structure is that this is a federally purchased vaccine. It's not something you can go to the local Walgreens to pick up. And it is distributed to the states in a way that has been reflective of how much illness is in each state, which I think is very appropriate. And really, it's been prioritized according to sort of two different ways of administering it. The first is for people who we know have had a recent exposure. Let's say your partner, a household member, a new sexual contact, or you know to have monkeypox. That's a kind of situation where if you've had the sort of intimate skin-to-skin contact we talked about earlier, and you're within 2 weeks, ideally within a few days, that this is a vaccine that can likely reduce your risk of developing active monkeypox. That's the reason why our contact tracing plans are so important. When we find someone who's positive and we want to have a good history with them, like you would remember from a couple of years ago with COVID, understand who else might have been exposed inadvertently, reach out to those people, see if this vaccine is appropriate. That's priority group number one. Within that, and reflecting on David's comments about sort of the recognition that this is mainly transmitting through male sexual networks and partner networks at this stage, understanding who may have had recent exposure is also important there. And we sort of use that as a post-exposure prevention technique. Where I think we all want to get to, or maybe I'm speaking for myself here, is when our supply increases sufficiently is to say, I don't want to only find people who've been exposed. I want to actually offer really good prevention to people who may become exposed in the future, such that it's a non-issue. And I think as we really get our supply chains up and running, then we can talk to patients and say, look, if you think you're at risk, let's go ahead and do this. It is a safe vaccine, and that we should roll it out as much as we can, supply dependent. Currently, the way that we've done that within the state is to really focus on 8 counties across the state who've had cases and have health departments that have robust ways of administering vaccine to large groups of people. This is not every county, but it's really focused on large communities where the resources within that county allow us to distribute the vaccine as quick as we can. And these numbers obviously will be shared at the end of the day. Separate to that, recognizing that this is also important, particularly amongst MSM communities, STD clinics, HIV PrEP clinics, and HIV clinics in general are starting to get access to this as we speak. So I'm going to now flip it to Lina, who can talk about some other prevention efforts. If I can work out how to stop my screen sharing, Lina. I think it's,
great.
I may still be charged by accident. There we go. Now it works.
I'm going to go ahead and share and switch over here quickly. See, is that looking okay to everyone? Great. Yeah, thank you. It's just so much incredible information from my 2 colleagues to start this off. And I'm going to try to round us out with just a brief discussion about sort of the behavioral factors and the stigma component to this. You know, we're really seeing sort of the same thing that we did in the early HIV epidemic, right? Where the gay community, the queer community is feeling this tremendous stigmatization, discrimination from society. And, you know, this is just in the last couple of days, lots of discussions online, lots of articles written, and you know, the Advocate, you know, major media outlets. This is a really big problem with any disease that is A, contagious, and it's, you know, B, disproportionately affecting particular communities that have certain demographics or that are marginalized in a way. The stigma is a huge component. And as providers and community and queer leaders, public health officials, we really need to have a unified messaging strategy to reduce the stigma around a disease, while at the same time making sure that folks are informed and aware and understand that there is a heightened risk within these marginalized communities. So what is actually being done at the federal and international level about the stigma component? So this is a highly contagious disease, again, that is affecting marginalized communities. And on top of that, it has this really awful, unfortunate name, right? So this is a problem that the WHO is trying to address. I don't actually know what the status of this is today. This was a conversation that began about 3 to 4 weeks ago, and there's an advisory board discussing actually renaming, completely renaming the nomenclature, not just the monkeypox name, but also the clades, and removing any traces of the geographic origin, because it is very discriminatory to Black communities and to African communities, right? So this is something that is happening at the international level, but it's unclear when this will actually be completed, this work. And at this point, we're so far into this epidemic that we're still sort of behind the 8 ball, right, in terms of addressing the stigma that is happening. The CDC also has put out some information about how to sort of frame communication and messaging around monkeypox. And I think it's helpful to kind of take a look at this and think about, how do we talk about monkeypox? How do we communicate with communities at risk? And I think this aligns quite well with kind of our general knowledge about how to communicate or how to frame messaging in a non-stigmatizing way. So they've sort of divided this into two channels. So first is the broad messaging to the public, and then the focused messaging to queer communities. So in terms of the public messaging that sort of goes out to everyone, and this rings true for any kind of messaging, right? Make sure that all messaging is fact-based. It's focused on providing people with resources and information so that they can act, so that they can protect themselves, so that they can seek care in a timely fashion. So fact-based messaging that is specifically related to means of transmission and seeking care and features of the disease. And then promoting monkeypox as a public health concern for everyone, because even though we know it is being transmitted within sexual networks and within particular communities, it certainly can affect anyone. So avoid focusing on queer populations specifically, to sort of minimize the stigma in that population, but also to avoid creating a false sense of security in other communities, right? Because it certainly can affect other people. Using images of typical cases, and I like the sort of broad range of cases that Dr. Wolfe showed images of. A lot of the medical literature, and if you Google monkeypox, you're going to see a lot of these very extreme cases, and that's like Dr. Wohl and Wolfe discussed is not really typical. So sort of avoiding the extremes to sort of create panic and again, increasing the blame on queer communities. And then using diverse images of affected individuals, showing lesions on different color skin. Actually, when you are creating outreach materials for certain communities, try to have a balanced and varied sort of demographic and cultural background of the folks that are included in images. And on a side note there, as a medical profession, we've always been just absolutely horrendously crappy at showing pictures of skin lesions on Black or brown skin. And it's something that is missing. And it's very important to educate folks on what these lesions look like on skin that is darker at baseline. So messaging to queer communities or to the MSM communities, which is a term that I'm not crazy about, but kind of going back to the extremes of images and things like that, the extremes of cases that require hospitalization, or that Dr. Wohl mentioned, brain lesions, lung lesions, those are actually quite rare. So avoid that alarmist messaging, particularly when you're speaking to the highly affected communities, but still provide fact-based messages. Do give tools and resources. Here, here are the numbers to call. Here's the local health department. Here's when to seek care, offering sort of those tangible things. And then using targeted channels to reach queer communities. So Brady is actually an expert in this and using particular social media strategies, using particular apps, using news and media outlets like The Advocate and Pause, and these sort of media sources that are available that particularly cater to the queer communities. And then, of course, adapting your messaging and the dissemination strategies to the specific community, and again, listening more than you talk, and trying to understand what the needs are of each individual community. So being flexible and targeting all your messaging to the affected community the best you can. Engaging trusted community organizations. I saw Corey on the call, a few other folks that are doing the hard work out in the community. Engaging community partners who really know and understand their stakeholders and their communities. And then always have a clear call to action, whether it's raising awareness, encourage seeking care, providing specific resources. So it's just a few more details then about kind of these behavioral components. And I think when it comes to overall stigma messaging, one of the points that I always try to drive home with folks is that when you're talking about risk, you need to really take a step back and avoid speaking about risk as a function of individual behavior. And you need to really think about what are the structural health disparities and the structural risk factors that are affecting the communities that you are working with. So stay away as much as possible from talking about risk as a product of an individual's behavior. So general strategies, of course, get vaccinated, like Cam said, seeking treatment early if you have exposures that you are aware of, or if you have any symptoms. Communicating with partners, all partners, openly and honestly. There's a lot of shame and there's a lot of shaming that's happening, anytime we're talking about an infectious disease, and always evaluate whether this is safe for you as the individual or the person that you're counseling. It may not be safe. Disclosure is a very sensitive thing, and we know that as HIV providers as well, right? So make sure that it's in a safe space. And then understand when you can spread monkeypox to others. And we did go over a lot of those details. So only when the rash is present, the skin contact is the most contagious. Also, compared to chickenpox and smallpox, we need to make sure that all those scabs are completely fully healed and scabbed over and fallen off. So a very long period of infectivity. More specifically, I already mentioned, it's really primarily spread through skin-to-skin contact, not exclusively, but this is sort of the primary way that we're seeing the spread. And so, of course, the best way is to avoid contact. But from a harm reduction perspective, this can mean getting creative. So sexting, virtual sex, like not actually being in the same room with each other, mutual masturbation, covering skin as much as possible, actually keeping some clothes on, going back to that, high school makeout session, the car, whatever you can do to sort of reduce the risk of the individual that the individual is exposed to. Avoiding kissing, which does not go along with the makeout session to car, but you see where I'm going with this. And then importantly, doing really good kind of infection control in your space. So cleaning your bedding, your sex toys, cleaning the bathroom. It's just sort of sanitizing surfaces before and after sex. I think those are some of the key points for safer sex strategies. Ethyl rubbing alcohol, the kind of old school rubbing alcohol, and hydrogen peroxide are the two that are the most well-established cleaners that we know of for what are called tier 3 viruses, which would include monkeypox. I think I'm going to pause there because we are quite a bit past 7, and would love to sort of kick it back to this group and sort of ask, as a community, how do we best push back on the stigma associated with these diseases that affect marginalized communities and that are contagious, right? And I would love to hear what folks have to say about that. Let me go ahead and stop sharing as well.
Great, thank you, Lina. So there were a few different questions that popped up too. So Lina, do you think we should pause to answer that question or take questions in general? What do you think would be best for what you're planning?
Let me see if I'm gonna pull up the chat and go back. I think while there's some stigmatizing sex negative shaming component, there's also a highly reactive piece, which could be summarized. We've been through this before. We try to watch over ourselves and our partners, and we're ready to do this. Yeah, David, do you want to elaborate a little bit more on your thoughts about this? Because I think this is a great point. If you feel comfortable, it's certainly not necessary.
Well, hi. Yes. Basically, as I've passed along in the chat earlier, that the community has gone through something like this before. We know what to do. We have the tools this time. And to Cam's a point about rolling up our sleeves. We're ready. The problem is, well, the difficulty is the translating that energy and messaging out to other communities as well. Fortunately, again, we've got COVID. Fortunately, again, we've been through something kind of like this with COVID. So we've got the tools in place, I think. It comes down to what are we missing? We've got the tools for the messaging available. What we're lacking are the tools for what we're lacking at present, at least in this area, is the broad application for biomedical prevention. And now I'll stop there.
Yeah, I think you bring up several really good points, David. You know, we certainly have a lot of lessons that we've learned from the initial HIV epidemic, and then the ongoing work that has been done since that, and in our COVID response, right? So there's a lot of stigma research that has been done and that we're drawing upon. And I think for me, one of the key pieces that we have always missed is that we don't listen well enough to the affected communities. And we're not sort of lifting them up and putting them front and center to lead some of these efforts. And so from my perspective, that's a big piece that I think has always been missing. And then in terms of the biomedical prevention and the vaccines and PrEP and things like that being available, your other points, you know, I think that is that's more of an outbreak response question, and our ability to respond appropriately and quickly to any sort of outbreak like this. You know, one of the benefits is of course that, you know, we have all this knowledge from smallpox and vaccines and medications that are working, but bringing that up to scale is a huge task, right? It's a massive undertaking, and it requires lots of logistics and money and effort.
And it's a different task too, because we went through the same upscale for COVID, but that was for everyone. Like here we're trying to really address risks that are different and still have the same increasing scale issues, but like reaching out to different communities, I think is just a different upscale project. It's challenging.
Yeah, and I do think, and it's great that we have so many of the folks who are on this call who really advocate and represent the well-being of LGBTQ communities. So I think, you know, you're deputized, you know, you have the information, and now just spreading the word, as we try to do always, to folks who are more impacted by anything, really makes sense. And I think we have to make sure we reach people across our state, no matter what language they speak. And I think this is a very, very first initial step, but now hopefully it will spread through you all. Brady's done a good job of trying to remind us that there are some other questions. This is a great question, and I'm going to ask Cam because, you know, it's very interesting to think about this, but I was born before 1972, and I have a mark on my arm. I was vaccinated against smallpox, so am I good to go and not have to listen to Lina, and I should be okay? Am I vaccinated and not going to catch smallpox?
I was not born before 1972, so I'll answer from the reflection of someone who does not have that lesion on their shoulder. Yeah, you know, so it's a terrific question, and I don't know that we have perfect answers, but let me tell you how I interpret it. What we know is that there was a monkeypox outbreak in 2003, and amongst healthcare workers who were responding to that, actually many had had smallpox before. No one got sick. A little bit different though, because they knew they were responding to monkeypox cases, and so were probably taking good protective measures. I haven't seen data yet that measures exactly the amount of risk reduction that occurs for someone who's had a smallpox vaccine in 2022's monkeypox setting. And so let me reflect some parallels with COVID. Like, we've got pretty familiar as a general community in understanding antibody response, for example. I can measure it for you, David. If you roll up your sleeve, I can measure what your antibody level is to that old smallpox amount. What I don't know is, I don't know what threshold that becomes really protective. Is that threshold different for different degrees of exposure, or different repetitive exposure, perhaps, if it's, you know, someone in the household or a close partner who's positive? And what does that do over time? we're learning this with COVID as we speak, aren't we? We're learning that slowly over time, our antibodies wane maybe more quickly than we anticipated. And so I would spin that back to you and say, I'm confident that you have some protection, but I'm also very reflective of a little comment the CDC have had this to say, if you had an old smallpox vaccine and you think you've had a decent exposure here, or you're identified in a contact trace, or you're nervous, then actually revaccinating you is probably a good thing to do. We do have data that supports people who had the old vaccine and then go on to get Jynneos do fine. It's safe, and you can have both, and in fact, they respond beautifully. So I think that's the take home, is that there's probably some protection. It's probably proportional to how recently you had that dose. Some of our military colleagues, for example, may have been dosed a couple of years ago. They've probably got a much better protection than someone who was dosed as a child. But it's really hard to measure that. And I don't think we have great methods of understanding what that translates to. So if you think you're at risk, I'm going to encourage most of my patients that we probably need to redose them. I hope that answers your question.
Yeah, no, it's a perfect answer. I think that's good. So it probably has some impact, but it's hard to quantify, and we shouldn't count on it. I want to make sure also, Zach, that we give you a chance to fill us in, because you're really working tirelessly on this, and your team and Vicky and others, and other things that we haven't covered, other things that you want folks to know coming from the state.
Thanks. I appreciate getting to be part of the discussion and listen to this. I guess just one thing I would want to emphasize, which you mentioned when you talked about our state data, but just to really call it out, is that we are seeing already, even with our first, for now, 24 cases, the disproportionate impact or disproportionate number of cases in Black and African-American men, more than 60% of our cases. And with our limited numbers of vaccine doses that have been given so far, 75% of those have gone to recipients who are white. So just to get back to the earlier discussion about, how we reach out to folks and making sure we get to the right people, that's something that we're very conscious of and thinking through with right now our limited amount of vaccine doses that are available. But as we start getting more doses, making sure that we're, bringing in the right people, the right groups to the discussion to figure out how we can start to fix that imbalance and get our vaccine to the people. This is not just a North Carolina thing. We actually noticed it in our data when we weren't seeing it in any of the other stuff, but I've been hearing it from other states as well. So I think this is something that I just want to call out as an important part of this outbreak right now in our state and probably beyond.
And yeah, so that's really key, because I think for many of us, it'd be like deja vu again of what we saw with certainly COVID-19 vaccination and rollout. And so I think at this early stage, any of us all the partners that are on this call, and there's a lot, thinking about now what we can do to make sure that there's more equity in getting people the vaccine now that it's just starting to come along. So I know HIV clinics are getting an on-ramp to getting these vaccines. As Cam mentioned, we submitted our paperwork. I think as we administer this, we have to make sure we reach out to people appropriately, and not just maybe some of the hand raisers who are really eager, but everyone.
It's a really fine balance, isn't it? Because the media has already portrayed a number of high throughput, big city clinics where it's like, we're going to tweet today, and those of you that can get here will get it all, and we'll give 400 doses. I don't know that that's an equitable distribution. In fact, I'm pretty nervous it's not. And yet, I think we have to be honest and say, I don't know that we've done a perfect job, Zach, to your point about a sort of an African-American and Black disparity there. I think that's reflective of many ways that we've reached out in health disparities there in general. We've got a lot of homework to do there to get a lot of questions to ask to make that better.
Yeah, and to David's point, we did see some of these same patterns in COVID cases and COVID vaccines. So there's a lot of lessons learned and a lot of, great partnerships that were formed around that we're trying to lean on. But this is different. This is not COVID in any way, so that's going to be a challenge.
We could do it. I know we could do it. We've done it before. It took us a while to crank it up. And I think the information you just shared with us now is an early warning flag. I think motivates me certainly to make sure we do everything we can to reach out to folks who need it, especially given the early indicators of disproportionality in men who have sex with men who are of color. So we definitely, and I think part of this too is who's getting tested. We don't know. I mean, there's a lot of folks who haven't gotten tested yet in other communities, whether it be Latino communities and others that we saw also with COVID-19. We were slower than we should have been to respond. So I think this is really important. There's been some questions about the recording, and Phil is on the line. So Phil, can you share us in how people will be able to get a copy of this recording to share?
Sure. For folks that joined tonight, we're going to output a file, an MP4 file, which is a video file for your computer, and we'll put it in a folder that you'll be able to access and download it. So sometime we'll have it available tonight.
It's great.
It'll be a big file. It'll be a very big file, so don't try to do it on your phone.
Yeah.
Are you saying we talk too much?
It's
He's
those
saying it's an
cat
important
pictures.
I
topic.
did not say that.
Those cat pictures, they take up a lot of megabytes. Yeah, and I will, on our side, we'll try to think about ways that we could maybe put it on a website or something like that, where people can just go to the website and then download it from.
And if you want to, we can upload it to YouTube. We could do that tonight. So I don't know how you felt about it. If you want it that way, you can see it and get to it. Or we'll also make it available and you can get the actual file. So if you do want to cut it up and use, pieces, Duke, UNC,
Happy to share it, David. And
Yeah, that'd be
there's a
great.
question that's come up twice here about
Yeah.
kids, and I think it's really worth talking about. Kids in pregnancy have always been the sort of, and immunosuppression, I would count as the three sort of special categories that give me a little more anxiety here. To be fair, I think both the pregnancy and the childhood data is extrapolated from what we've historically seen as monkeypox has occurred in West African countries more traditionally. We don't have a lot of experience of that, knock on wood, in 2022 here. But the proportion of lesions tends to be higher. The likelihood of more severe cases with perhaps internal involvement has been more notable. I have to believe that relates in some way to the immune response capabilities of younger children. Their immune system is more naive, it's more nascent, it's learning. And true of many viruses, frankly, it learns a little less efficiently than maybe our adult immune systems do. So when we think about how kids might get exposed, I think that's a relevant question though. So there have been situations where household transmission events have occurred where, for example, an adult in the house has inadvertently passed to kids. And I think that, that'll be something that's on the front of my mind for sure. I think the pregnancy issue is relevant too, because it highlights the fact that there's, the virus doesn't care what gender or what sexual identity you have. It cares about what your contacts are. And excuse my computer going off. And so again, if someone in the household or someone who's contact with you happens to be pregnant, there's absolutely every reason they can get infected at the same pace as someone else. But pregnancy alters your immune system's response again. And so the potential there for pregnancy is almost immunosuppressive in some strange way. And so we see many illnesses become a little more severe for women who are expecting. Likewise, if your T cell count and if you're HIV positive and your CD4 count is particularly low, has traditionally been a little more severe.
Yeah. And again, a lot of what we know about this comes from our experience in Central Africa. And it is different for reasons we don't completely understand. Almost all the disease we've seen outside of that area is characterized by much fewer lesions than we've seen. So we don't understand this yet. And I think there'll be a lot of work that's going to try to understand why we've seen some attenuation of the clinical presentation outside of Central and Western Africa.
And no mortality, which
No mortality. And
be
again,
crucial.
healthcare systems there, super infection with bacteria. These are things that may affect nutrition. There's a bunch of things that we have to look at, and immunological responses. But this again points to something that we should just say for sure and believe is this is another reason why we need to try to deal with these infections at their source. If we had dealt with this, there's been thousands of cases. Right now, there's only 243 or 200 and something known, but there's thousands of cases of monkeypox in those parts of Africa every year. Yet no one pays attention to it. So this is another wake-up call. There will be another virus that comes from there or somewhere else that will impact us. And this is the same area where HIV, basically, especially in that western part, came from a long time ago, and where Ebola now has spread from Central to Western Africa. So there's patterns here. And with climate change, we think that some of these are going to get worse because of the environments. The niches are expanding. So there's a lot going on there. So we really have to redouble our efforts and think about communities disproportionately impacted that are over an ocean away. I want to be cognizant of time. We're over an hour. If people have other questions, burning questions, they should type them in. I just want to make sure that we are able to get to your questions, because this is a really great opportunity. The other thing we're going to think about is really taking Lina's call to action to heart. How do we move forward? How do we do this in a way that's thoughtful? This is just a first attempt. This is not the last time that I think we should have folks communicate with good advice about different topics. And so I think that will be important. And your feedback's important. You probably have all of our emails. It's pretty easy to Google and get them. So email us with your ideas. Say, this is what we think we need. This is who we think you should have talked to us. This is how we think it should happen. And really get your thoughts, because we're looking for advice too, how to roll out to communities we're talking about. And so I think that's going to be important. Right now, I think what we really are in this very early phase of getting vaccine out there, getting vaccines are at health departments, getting vaccines to clinics, that's happening. And then the next step is getting more treatment available. I think it's just a little step behind, but I think there'll be more treatment available soon for when we need it. And then testing has already started. So I think it's testing, vaccination, treatment, and that's the march that we're seeing move forward, but we have to expand it. I'll finish with Ramona's and just get our take on this, and then we'll end, because this is probably the perfect thing to end on. Will we see a widespread outbreak? Is that unlikely? It depends how you define widespread. Many of us are worried that this may become an infection we just continue to see bop around, and at least for a while. And I think that's probably the case. I think a lot of folks get small lesions and they don't pay attention to them, and those might spread to somebody else, and so on and so on. So I do think that we're going to see that. And this is a little different than syphilis, let's say, where there really is more of a sexual component. This doesn't require sex to spread, right? So I do think that there is going to be some of this collateral spread in other ways, like we see in parts of the world where this has historically been for a while, where it isn't as much sexually transmitted, but close contact that happens even in households and familial settings. So I do think so. I don't think this is going to be a huge, we're going to be in lockdown, we're going to have masks on, but we also will never touch each other. I don't think this is going to go that far. And the tools we have are we're just so much further ahead than we were with COVID-19. And the scariest thing, people like Cam and I and others working with Ebola, I say Ebola is scary, but an airborne infection is scarier. Something that can jump through the air, through a room to infect you, or a plane or a train or a bus, is much scarier to me than something you have to touch or be really, really in direct contact with. So yeah, so we're fortunate that this is not that. So I'm hopeful. I think we have the tools. I think our state's done a fantastic job of being very proactive and being on the cutting edge and really trying to make sure we're all over this. So I think moving forward, we're going to be okay. All right, so this is part one. We'll have future opportunities to do this. So I appreciate everyone coming out last minute, late at night. Enjoy, be safe, and send us your comments and thoughts.
Please do. Thank you all for joining.
Thank you. Bye.
Thanks, everyone.